Okay, so my topic today is to talk about the management of the indeterminate nodules in the United Kingdom. Can we do better? First of all, I'd like to congratulate and thank my co-authors, Jean-Pierre Genon and Luigi Volpini. One of them is actually here to put this together for me. So I've got no conflicts of interest to declare. I just want to, although I have no conflicts of interest, I do want to have a dedication, and I think this is very relevant. This girl, Gabrielle Grunewald, who was a plasmarchist in the States, died recently, and I just want to show that she had thyroid cancer and adenocystic carcinoma of the parotid gland, which metastasized to the liver, and she was not actually afraid of her scars. And the second one is actually Gladys, who's was a very nice 34-year-old woman who was from London, who was originally from Lebanon, unfortunately died a very, very unpleasant local invasive polydifferentiated thyroid carcinoma at the age of 34, and we couldn't really do anything about it. So I just want my thoughts for those two very brave ladies. So I just want to give you a little bit of a background, the problems that we have in terms of indeterminate nodules. We did a survey on the current practice and how can we improve our practice in the UK. So thyroid nodules, as you know, they are very common. In the UK, new thyroid nodules can be referred to specialist centres as a suspected cancer. So therefore, you have a huge overload of new nodules. Unfortunately, we do have a problem with lack of infrastructure and clinical expertise everywhere, and that obviously causes significant problems. As you know, indeterminate nodules can take a lot of time and resource and cause anxiety for the patients who they don't know whether they have cancer or not. Obviously, we don't have all these very fancy molecular panels, so that's fine for the time being. We know that Donald Trump, in his recent visit to London, he was offered to take care of part of the NHS, so we'll see what happens. Maybe things have changed when I come back to London. So. And what is also happening is that in the UK, the healthcare providers, public or private, they don't allow us to use molecular panels due to cost, and also the regulation of what we call the National Institute of Clinical Excellence, which basically regulate what we can actually use in clinical practice. And also we know that obviously these panels are not 100% sure. We have also a problem with nomenclature. We may have even more problems with nomenclature if we go out with Brexit. But basically, as you can see, we have a very good correlation with the current Bethesda system. This is our seminal paper, which I was one of the senior authors on, where we basically establish the malignant rate in Thi3A, which is basically a Bethesda 3, and a Thi3F, which is a Bethesda 4. And you can see that the rates are there, and they do correlate very well with the current Bethesda system. So the problem, as I said, is that there's huge variability between units. There's what we call in the UK the lottery code effect. We do have, unfortunately, a very problem with the lack of a specialist expertise in cytology and ultrasonography. We do have a problem, with litigation fear, and so there's a tendency to call everything indeterminate. So, we see a lot of these reports by which they can pass to us that, well, they need specialists reporting or they need a specialist FNA. So we do have then no option but to do what that report said. In a recent paper by Ian Nixon, who was at the MSK when he was working in a district general hospital before he moved to Edinburgh, he published this paper, and basically he found that the diagnosis of indeterminate nodules in the periphery and hospital was not actually safe. So that's actually really, really worrying. So what are the consequences of all this? So we have a huge problem with increased number of so we call diagnostic surgeries. We do have an increased number of kind of waiting lists. We have healthcare pressures. Basically, all the patients that they come through what we call a 2-week cancer wait, they need to be dealt with a certain period of time, and then that causes a lot of pressure. And any indeterminate nodule that could potentially be cancer, that means that we have to kind of we need to get a diagnosis within 31 days or 62 days. And there's obviously an issue about cost as well. And also, we do have a problem, potentially, with increased risk of complications if these diagnostic surgeries are then done in the peripheral hospitals, perhaps with lack of expertise. So when I put this together, this talk, we invited Brian McIver to London to a meeting which was very successful. And then basically one of the questions to him was, what is the first thing you do when you're presented with indeterminate cytology? And he didn't say that we sort of all expected that he was going to have this panel and the other and all the rest of it. And he said, no, I repeat the FNA. So that's basically what really, potentially that's happening in the UK too. So the purpose of the talk was to basically to provide an overview of the current management of determinant cytologies in the United Kingdom, to highlight the current controversies and different practice in the country, and to propose some kind of perhaps valuable solutions, some of them potentially a little bit more controversial, and then I will explain that in a minute. So what's the current practice? So what we did is that we map the United Kingdom. It is a selective, obviously this is just a snapshot, but it just gives us a very good indication about what's actually happening. We did manage to map all the what we call principal MDTs of the country with just 14 questions. The sessions only took 2.54 minutes to answer those questions. And then this is the first slide. So how do you often do an MDT? So the majority of people will have only twice monthly MDT, 30%, 37% weekly, and about 12% monthly. So ideally, we should really have all this weekly. How many cases do you do? Could you discuss at the MDT? Well, the majority, less than 20, although this could have obviously been a little bit distorted. Then about 41% between 20 and 40, and only 8% of the surgeons or the MDTs more than 40. When we ask about how many Thigh-3s, so either Bethesda 3 and 4 cytologicals do you do, and you can see actually the results. So there's quite a lot of variability. Do you discuss the Thigh-3As, either the Bethesda 3, and then the majority of people would say yes, and so for the Thigh-3Fs, so that's the Bethesda 4. In terms of the diagnosis, very few people use core needle biopsy. And then, interestingly, we expected that nobody would potentially do molecular panels. In fact, we had basically 3 surgeons replying from 3 centers that they had access to molecular panels, which is quite a little bit surprising. And then when you actually ask whether these molecular panels would be helpful, then there was a split. In 3/3. Then, in terms of kind of the Thigh-3 results, you can see here, and then what we also ask is whether these Thigh-3s could be put in an active surveillance protocol, and in fact there are quite a lot of people who do have some of these patients in protocols. When we ask the standard care for a Thigh-3 or Bethesda 3, then the majority of people would probably recommend follow-up. And then when is standard of care for Thigh-3Fs or Bethesda 4, the majority of people will chop them out. So in terms of the when we do a diagnostic lobectomy, whether for the Thigh-3F, do you explore level 6? Only a few they bother to take some lymph nodes. The majority they don't bother, and then obviously we don't bother about intraoperative frozen section. When we did ask the surveyors whether they would be interested in or they consider to enter the patients in a national trial, well, it's quite good. The great majority, over 54%, say yes for both, and there are obviously a few reservations, especially for the Thigh-3Fs. So these are the comments. So what are the solutions? One is that we can potentially apply strict guidance criteria. Another one would be that we could improve clinical expertise and improve results. That is very difficult in the current healthcare system. And the other one would be to do a trial and obviously wait for a perfect panel to come through our door. It may be that with Trump taking over the NHS, maybe we can do that. I don't know. So in terms of kind of improving the resource, we did a study, and then the interesting thing is that what we did is that we did compare 2 cohorts before the centralization of services, which happened in 2007, and a second cohort after the centralization. And this is basically what we had before and after. And basically the main thing after that is that we had systematic, after 2007, we had systematic presence of ultrasound-guided fine needle aspiration cytology. We had the presence of a biomedical scientist checking the samples, and we had basically a central MDT, or multidisciplinary tumor board, that was basically checking every single cytology. And what we found is interesting. So our non-diagnostic samples went down perfectly well. The Thy3s, unfortunately, stayed more or less the same. And the Thy3s, we were actually picking up more thyroid cancers. And this is basically the review in our patch, and then you can see that we are essentially, which is the central MDT, and then we had the list of the indeterminate nodules. The others, they had up to, as you can see, 20% of indeterminate samples. So the conclusion was that having a centralized thyroid service, although which will help certain things, but not will help everything. So the way to forward, we said, can we do a kind of a follow-up trial? If there are people who have active surveillance for thyroid cancer, why we don't have, or when we cannot do active surveillance for thyroid nodules? And obviously we know that what the problems are, and so we thought that maybe that it would be a good idea to do. And the purpose was basically just to look at that. When you look at the map, when you map the what could potentially happen, I think the benefits potentially outline the potential problems. This is the inclusion and exclusion criteria, which I'm very happy to share if you want to kind of read them afterwards. And the methodology would be that everybody should really be discussed at the central MDT, that we should really randomize, we should counsel patients, we should use obviously quality of life questionnaires, and then we should do all the usual kind of checks. This is the trial protocol, and basically we would active surveillance nodules less than 2 centimeters at 3, 6, and 12 months, and there's no change, then we can actually do that, the active surveillance, for 12 months up to 5 years. And then if not, if they increase in size or if anything changes, that we could offer the patients a thyroid lobectomy. And these are basically the numbers